I think next we have Dr. Jayanto Shekhar Guha. He'll be speaking to us on managing recurrence in diabetic vitrectomy. Please.
Thanks, Ajay, and thanks for the kind invitation, the scientific committee. And two great institutions I've been a part of in my city of birth, Kolkata, Don Bosco Park Circus and National Medical College. Having said that, my topic is managing recurrence in diabetic vitrectomy. After the videos that Praveen shows, so elegant videos. So this is a difficult act to follow. We all know the primary goals of vitrectomy are to clear media opacity, stabilize the proliferative process, and to increase the retinal blood flow. Now, apart from the recurrence of diabetic macular edema, which is a different topic altogether, I'll dealing with the other recurrent factors and also elucidating the preventive steps that one takes in the initial surgery to prevent these recurrences. That's the recurrent ERMs, as shown in this picture. Now, risk factors for ERM is active PDR. I won't go into theory much. And the interface between siliconal and retina is a very important factor because of the accumulation of growth factors. Now, this is a case where is a case of post-siliconal removal recurrent ERMs. You can see the extent of the ERMs from the posterior pole to the periphery, which I just showed. And the membrane peeling here is a different ballgame altogether than the usual ones with the usual vascular epicenters, because the recurrent ERMs don't follow the same pattern as the initial ERMs. So more than you have to release the forceps, follow the vectors, and then sometimes it becomes a gut feeling. See, it could have gone the other way around and created a tear. So, and that's how you remove, and then we will do ILM peeling in this case also after the ERM. That's it. So preventively, whenever we are doing a TRD repair, I routinely follow ILM peeling because it restores retinal elasticity and aids in resolution of the persistent submacular fluid. So this is the ILM peeling that we usually do in TRD cases or in diabetic macular edema cases to prevent recurrent ERMs. Now, breaks. Breaks iatrogenically can occur during dissection of membranes, frequent during vitrectomy for PRD. Of course, it has the significantly lower incidence in the era of 23 gauge and 25 and 27 gauge vitrectomies. But posterior breaks are more, have a fearful outcome than the peripheral breaks, and only breaks associated with adjacent traction limit anatomical success. Like these atrophic breaks taken from Ramesh et al.'s publication don't need to be done anything. You just leave them alone. Now, how do you reduce the risk of creating breaks? By removing the anterior vitreous next to the sclerotomies. You must be very careful not to completely detach the proliferation from its base sometimes, because it's better to leave these bases alone so that they don't give rise to sciatic formation and later break formation, and use only sufficient diathermy to minimize break formation. And those with tight adhesions that do not connect to the posterior pole are best left alone. And I'll touch upon two aspects here, tackling attached hyaloid by using outside in and then inside out technique. So these are some innovative steps you will go along. I use a lot of posterior depression to tackle the attached hyaloid, as you will see, and use a lift and shave method so as to, because attached hyaloid are our biggest enemies for reproliferation and of course to prevent bleeding. So you can see that your shaving, and as well as sometimes, and you'll see in the later film how you detach successfully the posterior hyaloid. You'll see. And as Srinivas had shown very successfully, these cutters can go very near. Of course, this is not a mobile retina, attached retina, but even if it's a mobile retina, it's very safe to do surgeries. You can see the hyaloid being lifted here very well. And then you cut across, and then you have gone into the right plane. As Hemant would also show, going to the right plane is the surgery half done. Here is the inside-out method as it was being discussed, mini PVD as Sangeet calls it. You begin near the disc, create a PVD, and then you proceed along the planes. And you sometimes you have to create an opening near the hyaloid, as you would see in a later film. So you begin near the disc, inside-out method. So these are very important preventive steps to prevent recurrences. And I'll just fast forward some films. So here we complete the rest of the surgeries, and now we'll deal with recurrent hemorrhages. As in the area of smaller sclerotomies, valve systems, controlled intraocular pressure, we don't have much bleeding, but still it's an important thing that we have to deal with in repeat surgeries, and it has not been significantly less in small gauge as compared to 20 gauge. These are the usual causes of recurrent hemorrhages, and the management of recurrent hemorrhage is the usual. Sometimes it clears spontaneously, but revision surgery is often needed. And we'll go to the this aspect of clotted blood. It sticks on the detached retina situation, and then it becomes a difficult situation which you have to manage bimanually by using a bimanual method, very, very careful. And you usually leave a stalk at the end, as you would see, so as not to recreate. Yeah. So I'll go to my last video then. So Aminda was asking how to control disc bleeding. So you create, and bimanually you use a suction and a heme stopper, which I used in this case after cutting the stalk. And I press upon that, and in sometimes 1 minute, 1.5 minutes, the bleeding stops. Then you lower the pressure, examine again, and then conclude. Now, another very important steps I want to show. Give me a few more seconds. That these are red flag sign which we often talk about. That to prevent recurrence hemorrhages, we have to go at the very near the vitreous base and clear the hemorrhages, because these are a very common cause of recurrent hemorrhage. And it's very easy to depress, especially in a pseudophakic situation, and even in a phakic situation, it's not as in this case. You just have to never go across diagonally, just put your depressor and so that the cutter remains on the same side, and you, without touching the lens, you can remove those hemorrhages. The last. Now, periphery has to be lasered right up to the aura to prevent, to ensure adequate anoxia so as not to have recurrent bleeds. And last, I'll deal with recurrent detachments. As Praveen showed elegantly, sometimes you have to use air. It's very, after you have cleared the posterior hyaloid, the peripheral vitreous can be effectively cleared very well, as is shown in this case, under air. And
Doctor, you can conclude, please.
Yeah. So last. So this is a tug-of-war technique that I use to prevent, to tackle the recurrent detachments. Sometimes it becomes a crunch-like syndrome. So use 2 forceps and you pull them apart tangentially to tackle these membranes. So thank you so much.
Thank you, Doctor. Thank you. So you showed all the medley cases which we can come across in diabetic retinopathy. Thank you so much, Doctor.